Good morning, everyone. I am so honored and humbled to be here. I might ask for a little grace because of the gods of Monday locked my speech behind a blue screen this morning. If you're familiar with the dreaded Monday morning reboot. So I had does anybody remember that episode of Friends? Ross in Barbados loses his speech and he's like scribbling it. So that's what I've been doing for the last hour and a half, as best as I could remember it. Um, there's a metaphor in there somewhere. I'm not sure what it is, but ask me later this afternoon. But let's get to it. Um, I started at the department 9 years ago, administering those programs for pregnant and postpartum people. And at the time, there was this emerging anxiety from providers like you that there was this increase in prevalence of substance use disorders among pregnant people with novel presentations associated with the opioid epidemic and polysubstance use, and that this was creating more challenges in treatment. And luckily, this has led to an improvement in evidence-based protocols that you in this room have pioneered and implemented. And since that early point in my tenure at HICPUF, not only has my career grown, but so too has this field. So I wanted to ground us today in some of the great work that's happened or is in progress. But before I do that, I want to just share that at the state, we take very seriously that we are our stewardship, that we are stewards of the will of Colorado residents. With that comes this ethos of responsibility to manage dollars and resources, and ultimately the dreams of what is possible to affect change for this population. And that dream is the collective vision and the work that you have created in this room. So first, though it's not always sexy, I like to point out that there has been a tremendous investment in the state in our data and using that data to make really informed decisions. So first, the Colorado Department of Public Health and Environment, my colleagues over there have been working on the Maternal Mortality Review Committee for years, but it really lacked a state investment in that program. So a bill in 2019 codified that work in statute, and among other things, it invested more money, it allowed for more diversity in voices, and allowed them to make recommendations based on that data to the state. Many of those recommendations I've been able to leverage through our Medicaid and CHIP populations to make those informed decisions. Similarly, now there's the Colorado Baby and Youth Survey, formerly known as Healthy Moms. Lost the dates on that on my speech. I think it was 2019 to 21 and approximately 2,500 participants. Don't quote me on that. Were surveyed about their experience. And they almost lost funding in 2022, and then they were reinvested in. And so now they are still working on these surveys. Again, some of you probably participated in redesigning those, talking to birthing people in the state about what does your relationship with providers look like, what resources supported your breastfeeding, or what were the stressors of returning to work, capturing this increased understanding of matrescence in Colorado. But the department was not immune to needing to do this, my own department, HICPUF. And so we leaned in, and I say we, and I mean our very, very smart data people were able to match our Medicaid members to CDPHE birth certificate data to give us a more holistic picture of what was happening with our members. This has resulted in two reports, one on 2019 data, one on 2020 data, that allow us to say really powerful things like in 2020, our rate in Medicaid of substance-exposed newborns or newborns born with neonatal abstinence symptoms was 3.8%, which was a 30% increase from the previous year. Upcoming reports will show what this looks like more longitudinally with some chart packs, and also increase the use of member voice. So similar to kind of like what CDPHE did with those surveys, we also have the Maternity Advisory Committee facilitated by Anushka, who is in the room here, which was formed by the request of advocates who asked how members were influencing critical policy change, things like value-based payment. And so in 2021, we created a committee that must be primarily composed of Black, Indigenous, and people of color. It's 16 to 20 individuals with lived experience of giving birth on Medicaid within the last 5 years. We also have a mental health professional on staff with that work to make sure that it is trauma-informed and safe for people to share their stories. And so there will be an upcoming, more qualitatively focused report that includes the stories from those members, as well as the results of a statewide survey on the experience of giving birth in Medicaid. And all of this is so important, like I said, so that we can appropriately invest our resources. So what has this helped us figure out? These are only going to be some highlights of that work. It is not a comprehensive assessment of that work. So forgive me if I leave something important off of this. One is in 2021, we were able to use maternal mortality review committee data on the increasing incidence of mortality in that 61 to 365 days to get guaranteed coverage for our Medicaid members through 365 days. Yeah, it's really cool. So really thinking about transitioning to that fourth trimester paradigm and how can we support parents in that time. Additionally, thinking about the intendedness of pregnancy and knowing how that impacts outcomes, we have expanded our family planning programs. We now have family planning and family planning related services available to an expanded income range for those who may no longer qualify for Medicaid or CHIP, but can't quite make enough to make it onto the marketplace. Additionally, we have family planning and family planning related services for our folks who would be eligible for Medicaid, if not for citizenship status. And that program will be growing shortly. I'll get to that. CDPHE is also focused on building pro-social connections as a way to increase the support of communities and community health workers to support pregnant and postpartum people, speaking to bringing the work outside of hospitals and how can we strengthen those partnerships. So I feel like I've spent the last year gestating 2 babies. One of those I'm currently carrying. The other one is a doula benefit for our Medicaid members, which will go live in July of 21. As you probably know, these paraprofessionals show a great impact on improving outcomes with some particularly exciting data on SUD. That's similar to community health workers, which will be a benefit going live in July of 25. So expanding that from just beyond doulas to think about other perinatal community health workers that can be of the community, serving the community in ways that we know really resonate for these clients. Finally, I think I saw like a 2-minute mark, so I think I'm doing okay. We'll have a full look-alike benefit for Medicaid and CHIP for folks without documentation. Previously, like I said, we have family planning services. We also provide emergency medical services, which usually looks like labor and delivery for our pregnant and postpartum people who are either not getting prenatal care or having to source it from a variety of ways, sometimes at a great cost to our hospitals. But now we will have pregnant and that full 365 days coverage, and then also for children through up until their 19th birthday, which is very exciting. This is not to mention our hospital quality improvement project, our hospital transformation project, the work of our accountable care collaborative. It's a busy time, not to mention the maternal opioid misuse model, which is a $4.6 million 5-year cooperative grant with our federal partners. Again, talk to Anushka and our colleague Molly over there about that. Still in development, we have our 3rd iteration of the Accountable Care Collaborative and an alternative payment model for maternity care that's trying really hard to do something innovative where we focus on equity and patient experience instead of just reducing costs. So I'm tired of trying to read my handwriting and you're probably getting tired of this laundry list. So I do want to say before I summarize that we are going to be shifting into kind of this idea of evaluation and stabilization. We've done a lot of work. We still have a couple big check marks on that list. But we do it well enough is a good question. And did we do it well enough to honor the work you do, the vision these programs came from, the will of the people? As I said, it's a tremendous responsibility to capture the labor of the people who are passing the bills, drafting the amendments, seeing the patients, writing the scripts, updating EHRs, reading Colorado Sun articles, calling your legislators. Like, it's a lot of work. We get to stand up here and showcase these programs, these initiatives, and talk about our team. But really, it's not our team's work or our office's work or our department's work. It's the work of Colorado, and it's really powerful, and it's really exciting time to be here doing this work. So with that, thank you all again for having me here today. Thank you for the work you do, and looking forward to an exciting day of hearing from you and learning from you.
Thank you.
Thank you.
That was amazing. Susanna is leaving here with loose leaf paper with like the binder frayed edges. Amazing. Thank you so much, Susanna. And I'll highlight that within Chosen Quick, we collect some limited sociodemographic information and we collect insurance. And we know that nearly 90% of our maternal infant dyads are Medicaid insured. I'll also say that the majority of Chosen Quick funding has come from the Colorado Medicaid Upper Payment Limit Program. So we have a very important, deep relationship with HCPF and Medicaid of our state. And so it is real important that we continue to work collaboratively moving forward. So thank you, Susanna, for coming.